Good day. My name is Marelize, and I am a medical scientist at the National Health Laboratory Service in Cape Town, South Africa. Today, I will be talking about the utility of constitutional chromosome microarray analysis in pre and postnatal diagnosis. So, South Africa, where I'm based, is located at the southern tip of the African continent, and we have a population of about 60 million. About 3 to 4 million South Africans have a rare disease, and the NHLS services more than 80% of the population. And we have 3 genetic laboratories in South Africa within the NHLS, and these are in Cape Town, another in Bloemfontein, and the third in Johannesburg. The laboratory where I am located is in Cape Town in Groote Hospital, and this is what it looks like. So just a bit of background information on structural variants. These are variants that are larger than 50 base pairs in size, and they can be balanced or unbalanced. And in fact, about 40% of previously thought to be balanced translocations on karyotyping are in fact unbalanced when using higher resolution testing such as microarray or NGS. Structural variants include insertions, inversions, translocations, and also copy number variants that will be the focus of the talk. So just as an example of what a deletion looks like, it is if a piece of a chromosome is deleted or missing. An inversion is when a piece of a chromosome is rearranged and inserted in the opposite orientation. And a translocation is when one portion of a chromosome is attached to another portion of a chromosome. Copy number variants are when a specific piece or segment of DNA is different between individuals. For example, in individual 1, the orange section of the genome is inherited in 3 copies from the maternal side and also 3 copies from the paternal side, resulting in a total of 6 repeats for that particular region. Individual 2 also has 6 repeats for that region, but in this case, 5 are inherited from the mom and 1 from the father. And in individual 3 has a total of 8 copies of the orange region. So there's a database called Nomad Structural Variation, and they have included data from about 14,000 genomes and detected a median of over 7,000 structural variants in each genome. But when you compare different populations, you can notice that Africans are genetically diverse and have a higher median of structural variants per genome compared to, for example, European population. And principal component analysis shows that African individuals cluster differently and distinct from the other population groups. But there's also diversity within Africa, and this diagram shows that the East Africans are genetically different from West Africans and are different from Southern Africans. The challenge is that there's limited published knowledge available on the unique copy number variants that are found in Africa. So the role of copy number variants in disease is increasingly recognized, and the 2019 European guidelines provided information about when to test for copy number variants in the prenatal or postnatal setting. And this includes congenital malformations, a normal aneuploidy test, increased nuchal translucency, and also previous pregnancy with a chromosomal anomaly in prenatal cases. And for postnatal cases, this includes intellectual disability, features of autism spectrum disorder, other neurodevelopmental disorders, and any congenital anomalies. In 2010, the microarray analysis was considered the first-tier clinical diagnostic test for individuals with developmental disabilities or congenital anomalies. And then in 2021, the American College of Medical Genetics and Genomics guideline now recommends exome and genome sequencing for pediatric patients with congenital anomalies or intellectual disability. This is a diagram that's an example from a paper from 2017 that shows that microarray analysis can detect copy number variants that were not previously seen with karyotyping in ultrasound abnormalities and advanced maternal age cases. And this can find an additional 5 to 10% of fetuses, copy number variants in fetuses with ultrasound anomalies. We have started a diagnostic service for using microarray analysis in 2016, and we service the coastal region of South Africa with mainly referrals from the Western Cape, Eastern Cape, and KwaZulu-Natal provinces. We do very few pre or neonatal patients, and our majority of cases are children with intellectual disability, autism spectrum disorder, or multiple congenital abnormalities. For the external, for the prenatal and neonatal service, we use an external referral laboratory that performs everything from sample processing to report writing, and this is the Unistar Medical Laboratories. They make use of the Agilent Technologies GenetiSure Cyto 8x60K array. This array has about 60,000 markers. And because it's only a CGH array without genotyping probes, it cannot be used to detect regions of homozygosity. In the prenatal and neonatal service, we have tested 94 patients in the last 2 years, and of those, 18% had an abnormal finding. The most common were losses of chromosome 22q11.2 in 3 patients, and this was followed by losses of the 5p15.33 region in 2 patients. An interesting case is a male that was a neonate at the time of testing, and in his array analysis, 2 mosaic gains were detected involving chromosome 9, and both copy number variants were classified as variants of uncertain significance. Then shallow NGS and FISH testing was performed, and the findings from these tests suggest that the 2 copy number events could in fact represent one event involving the centromere or even a larger structural variant, for example, a supernumerary marker chromosome. It could be a heteromorphic variant without any phenotypic consequences, or it could in fact result in his phenotype. So a review of the Decipher database shows that there is one case with a gain that is similar in size on chromosome 9, and that particular patient presented with an abnormality of the forehead, cryptorchidism epicanthus, feeding difficulties in infancy, a number of other abnormalities, and tracheoesophageal fistula. Interestingly, our patient presented with also tracheoesophageal fistula, and in addition, tetralogy of Fallot and intrauterine growth restriction and a transverse palmar crease. Unfortunately, he passed away and parental testing could not be performed yet. For the postnatal service, we use this service from an external referral laboratory called CPGR for the sample processing, but we perform the data analysis, interpretation of findings, and report writing. For this service, we use the Affymetrix Cytoscan Optima array with about 300,000 markers, and this provides a minimum resolution of 1 megabase for losses and 2 megabase for gains in size. And this array has both CGH probes and also genotyping probes, and therefore this array can be used to detect regions of homozygosity and ploidy. The process of this microarray process involves DNA digestion, ligation, and amplification, followed by fragmentation, and then labeling. And then the fragments are hybridized to the Optima array. And Any unhybridized fragments are washed away before staining. Then staining is done, and then finally scanning takes place and data analysis. And as I mentioned, the Affymetrix array platform has the capability of genotyping at multiple positions across the genome. The software that is used for data analysis is called the Chromosome Analysis Suite software, and this is an example of what the software looks like. We follow a lengthy process during the interpretation and classification of findings, as can be seen in this diagram, and we use a number of databases and also published literature, for example, Nomad SV, Decipher, OMIM, Literature Search, the ClinGen copy number variant pathogenicity calculator, and also unique ClinVar, VARSOM, and others. During the interpretation process, we follow the ACMG technical standards, and we consider various things, for example, the type of CNV, the size, how many genes and which genes are included in the copy number variant, as well as if it's a de novo occurrence or inherited. Mosaicism is an important consideration, and also copy numbers variants that are associated with variable expressivity and incomplete penetrance. We don't report benign and likely benign copy number variants, but we do record them for further analysis. We do report variants of unknown or uncertain significance, likely pathogenic variants, including those with low or reduced penetrance. In the last 3 years, we have tested 762 patients and identified a total of 858 copy number variants in this group. 156 were benign or likely benign CNVs, 83 were VUSs, and 150 with pathogenic or likely pathogenic copy number variants. And interestingly, a large number of variation seems to be on the X chromosome. 28% of the individuals had at least one pathogenic or likely pathogenic copy number variant, and the most common findings were the chromosome 1p36 microdeletion syndrome, as well as Wolff-Hirschhorn syndrome, followed by loss of the terminal end of the long arm of chromosome 4, cat-eye syndrome, Dyche-George syndrome, and then also monosomy of the X chromosome. About 45% of the benign or likely benign CNVs were not found in the DGV database, which is a database of seemingly unaffected individuals. And this finding can suggest that there are potentially copy number variants that are unique to Africans. And the most common of these copy number variants occur on chromosome 4, 14, the X, and the Y chromosomes. An interesting postnatal case is a male that was 2 years old at the time of testing. He had previous karyotyping that was resulted as 46XY. And when microarray analysis was performed, we detected multiple copy number variants involving chromosome 2. And this is quite interesting as a number of these occur very close in proximity, and it involves duplications and deletions of the long arm of chromosome 2. And zooming into this region, one can see quite a large duplication followed by multiple duplications and a deletion. This case presented with hypotonia, developmental delay challenges, facial features that were dysmorphic, and also hands that are square-shaped, failure to thrive, and a vision abnormality. And this finding suggests that these copy number variants are likely the result of a complex structural variant. And because multiple regions of the chromosome 2 is involved, he could potentially have a combination of clinical features from these different regions. And this makes clinical correlation very challenging. So just to conclude, Our postnatal detection rate of 28% clinically relevant copy number variants is higher than what is typically reported. And this is likely because of the strict selection and gatekeeping of test requests in our resource constraint setting. We found a number of benign or likely benign copy number variants that are not in DGV, and this is likely related to the limited data on African populations. There is a need to expand the databases and build knowledge on the genetic diversity in Africa. There's also a need to do further research on the unique VUSs that we identified to determine their significance, as this can then be used to improve recurrence risk and variant interpretation understanding in our setting. I have used a number of references throughout the presentation that are listed here. And I would please like to thank the patients and their families, as well as the genetic service clinical teams at the various hospitals, and also the staff and members involved in the diagnostic testing at the Human Genetics Laboratory in Cape Town, South Africa. Thank you for your attention.